Okay, I'm sure you can hear me loud and clear. So let me welcome everyone who's joined us so far to the 13th edition of Conversations with Isobasi. So these conversations are an initiative of the Cross River Movement, and they're aimed at engaging and bringing people together to exchange ideas that can foster the development of Cross River State. We know that health and well-being of people is a basic necessity, for a productive society. If people are not healthy, they can't create wealth, they won't be happy, they cannot be productive. So how we deliver healthcare services, across Cross River State, especially to people who live in the rural areas of the state, is very, very important, you would agree. So in this conversation, we're going to be discussing working towards improved healthcare delivery in Cross River State. And as usual, we have a great array of respected professionals on our panel today. And I'm going to be introducing them, and this is in no particular order. So we should have, or should be having, if we don't already have, the permanent secretary the Cross River State Ministry of Health, Dr. Iwara Innocent. We should have also Dr. Janet Ekpeyong, who is a health administrator and is currently the Director General and Executive Secretary of the Cross River State Primary Healthcare Development Agency. She's also served as health financing technical advisor to the TB, HIV, DRM, and PFM activities. She's a firm believer and is a committed fellow to attaining universal healthcare coverage in Cross River State beyond 2023. 2023 is around the corner. We also have Professor Edet Ikpi, who is currently a consultant urologist with the Prince Mutaib bin Abdulaziz Hospital of Al Jaw region in the Kingdom of Saudi Arabia. That's a mouthful. He was until recently professor and chairman of the Faculty of Surgery, Liberia College of Physicians and Surgeons. Dr. Ikpi also served as Honorable Commissioner for Health in Cross River State between 2008 and 2012. We have Dr. Yemisi Femi Pius, who's an accomplished professional health physician with over 15 years of experience in health project management and improving health outcomes. She's led and managed the delivery of healthcare projects in maternal and child health, sexual and reproductive health, HIV, TB, and digital health and health systems strengthening. And finally, we've got Dr. Harrison Ofyong, who holds a master's in public health from the University of Birmingham and is currently the media and publicity secretary for Nigerian GPs in the UK. So join me in welcoming them to this conversation. All right, so what we usually do at the start of these conversations, we send, or rather in preparation for the conversations, we send people out to the streets of Calabar to sort of sample opinion about the topics that we're going to be discussing. So if you permit me, I will share my screen and just play a video. Just hold on a moment. Let me just sort that out. Okay, I think we're good to go.
everyone, my name is Blessing. I'm out here in the streets of Calabar to seek the opinions of people about what they think of the healthcare delivery system in Cross River State. Join me as we go into the street.
Yes, I have visited the primary healthcare center around my location where I stay. The government needs to do more to update the facility, because when I visited that place, I was not really pleased with the way the government handled the staff welfare. Some of the primary healthcare workers were sitting outside. I think it's because they don't have enough space or the chairs are not good, so they had to manage with the few chairs they had outside. Whenever they are needed, they will now go in and attend to patients. So it's not very good enough.
Interesting when you go to the hospital, you meet different patients with different disease conditions, and you're able to put in one or two to alleviate pain and suffering from them. So I feel I am living my best life.
School environment is very conducive. We have the lab, we have the nursing procedure, room where we get to practice procedures before we go to the hospital to practice this thing with live patients.
There is deficiency of manpower in our health sector, and this is really dragging us back in delivering care. Professionals are so stressed, they had to do beyond what they ought to in a day. We need more manpower in our health sector.
Well, the primary health care center there is okay and functional, but boiling down to the staff nurses there, they are not enough. So you hear people complaining of services not being rendered immediately, so they have to wait for a long time. And then the doctors there are not easily available for emergencies. So sometimes they have to put a doctor on call, and before he gets there, so nurses also have to try their best to do the little they can while waiting for the doctor. So I think health centers actually, especially the one at Men Avenue, really needs doctors available.
Once you have manpower, you need tools. I think the government also have to look into the area of providing things like gloves, cotton wool, ventilated spirits. If you look at it, it's so burdensome on patients.
How about the machines?
Oh, we don't even have to talk about machines when we don't have the basis. We don't even have to go there. Let's only focus on these little things that we lay, tools that we lay our hands on to carry out duties. I think if we can get that, it will help revive the health sector, and our care delivery will be better.
They're also lacking some equipment as well, though they have, but they really need more. They also need the scan. Then their laboratories also need to be equipped. For example, you'll be hearing them talking about the cold chain system. They need a cold chain system where the vaccines can be readily available for use.
So I think government need to do more. Right now that there is no commissioner for health, and I don't know when we are going to have it, maybe in the next regime. So we need to have a person from the government that is looking after those facilities to make sure they are functioning to the maximum.
Welcome back from the streets. Now we know what people think about the healthcare delivery in Cross River State. We hope that the government will wake up to their responsibilities in providing an efficient healthcare delivery system that meets the need of our citizens. I remain Blessing, and thank you for joining us.
Okay, thank you very much. So I will point out that that we do throw this open at some point. So if you have a question or you have, an experience, something that you'd like to share, a comment, so you will have the opportunity to do that. For our conversation today with, I believe everyone is muted except for our panelists. If you do have a question or comment, use the reactions icon, and you can use that to indicate that you would like to come in, and then we can unmute you and give you the opportunity. Okay, all right. So do we have Dr. Iwara Innocent on? Edidion? Do we have?
Good afternoon, everybody. Not yet, sir, but we have Dr. Janet on the DG.
Okay, so is she a co-host so she can unmute herself? So let's make sure that all the panelists are co-hosts, no, they can unmute yourselves, so sort that out. Okay, so what we want to do first of all, is to, I guess, understand where things are with regard to healthcare delivery in Cross River State. So I think the first thing is, especially for the benefit of those who are not healthcare professionals and those who don't really understand the intricacies of delivering public health, it would be nice to have that understanding. So what are the primary health? What are the different levels, different layers of healthcare? What are the structures that support that? I wanted to direct that question to Dr. Iwara Innocent, being the PEMSEC. I don't know who I will push that to. Maybe Dr. Ikwe, you were commissioner for health. Can I throw that question to you, because I'm sure you would have that understanding and can share it with us.
Okay, thank you very much to the crew from the Cross River movement. I mean, this is a very exciting development. I think there's movement all over the world and movement in Nigeria. We hear all sorts of movements. So I think it's a great thing that it's happening back at home. And I want to thank you sincerely for having me on the program. And I join my co-hosts and colleagues to express our deep gratitude to you. Primary healthcare, basically, constitutionally, is the responsibility of the local government. I think when people have challenges with the services from the primary health centers, it's because of that disconnect in understanding who really has constitutional responsibility for a service providing unit. So the primary health centers ought to be completely under the control of the local government service because they are nearest to the people. And the intention for setting them up is to have health centers that are nearest to the people, providing the basic of care and keeping people alive while arrangements are made for those who require secondary health care to be moved to such facilities. So that is the intention for them. However, the challenges they have had needs to be understood in terms of the structure of the local government service itself and the ability to fund that healthcare center within their domain. So those are really the challenges I think the primary health centers face in providing healthcare to the people who are within those localities. I think in the course of the discussions, one will expatiate, but understanding this basic relationship that the primary health center in each local government area, in fact, in each political ward, because that's the way they are structured, each political ward of the state has a primary health center that serves as the nearest hospital, the basic hospital that serves the people of that political ward. And every local government in Cross River State, for instance, has up to probably 10 to 13 political wards. So you have like 10 to 13 primary health centers in each local government, and they are supposed to service the people. They are supposed to be provided for financially by the local government service. But whether the local government has the funds to provide for them so that they can meet with their responsibilities is a matter which probably this opportunity will allow us to discuss.
Okay, Prof, thanks very much. You mentioned you talked about the primary health care facilities being the closest to the people, and then I think based on referrals, people then go off to the general, depending on maybe the severity of condition. So are you able to give us an idea what sort of services perhaps are delivered at the primary level, and at what point things might get escalated to secondary health facility, for instance?
Okay. Well, at the level of the primary health center, the structure of the primary health center is supposed to answer to the expectations of the MDGs. Originally, they were structured under the MDGs and subsequently under the SDGs. So what kills our people the most in obstetrics would be women who do not have access to obstetric care. So can a woman have a safe delivery in a primary health center? That's what the primary health center is supposed to provide. So basic obstetrics. Now, the people who work in those centers ought to have some basic training to recognize when that delivery is becoming complicated and to expeditiously refer such patients to a secondary health facility where services, secondary services for obstetric care can be provided. Now, in addition to this, the MDGs sought to mitigate infant mortality. So children are dying. What is killing children the most was identified as diarrheal disease, pneumonia, basic things, malaria. So the primary health center is supposed to be equipped to provide those services to ensure that children don't die of dehydration. So simple basic things like oral rehydration salts, how to prepare oral rehydration therapies, basic antibiotics, first-line antibiotics to prevent a child who has diarrhea from dying, basic antibiotics that prevent a child who has a respiratory tract infection from escalating. When they don't have a response, when the response is not satisfactory, then they refer to a secondary health facility. Now, because it's in the catchment area, other people stray into the primary health center. So somebody who has an abrasion, a wound, goes to the primary health center to have it dressed, to have them taken care of. Somebody who has been seen in a secondary health facility, who's had a surgery, who needs some follow-up, can now have that follow-up in the primary health center. So the structure of the primary health center is to prevent the death of our women and our children who suffer the most because of the delay in access to healthcare. Now, if somebody comes to the primary health center with a non-specific abdominal pain, and eventually they think maybe this patient has an appendix, they can't solve that there. They are supposed to refer immediately. So training the staff to understand that this is a primary health problem which can be dealt with here, as opposed to a secondary health problem which needs to be referred immediately, is supposed to be part of what government should help those centers to achieve. And if they were able to do this, then you discover that a woman who has an uncomplicated delivery, who goes to a primary health center, can deliver her baby safely. She doesn't need to have a cesarean section or something like that. The child that she's delivered, who is normal, doesn't need to go anywhere. But if that child begins to have jaundice and they recognize that this jaundice is not responding to the basics like phototherapy or sunlight therapy, then they refer the child to secondary healthcare. So it's designed in such a way that if it is operated properly, there will be a seamless flow of patients who can get service at that center and go back home without needing to spend any extra to go to a secondary health facility, while people who require secondary healthcare services can go to secondary healthcare facilities. But right now, what you have is that somebody who walks into a primary health center with malaria, or somebody who goes to a secondary health health centers currently in Crossover State, and I beg to be disputed, are acting basically as primary health centers. Because the man who has malaria, the child who has malaria, all go to the secondary health center. It's not supposed to be so. They are now inundated with cases they are not meant to be seen as primary caregivers, and they don't have enough resources and the time to take care of the cases they actually are supposed to be given. So strengthening that primary health level of care takes away the burden of secondary health care and takes away the pressure and allows them to do what really they ought to be able to do. And it also gives the people a sense of ownership, because these primary health care centers are sited within political wards. The people who work there, they live with you. You can easily access them. So they are the closest to people. And because of this closeness, somebody can easily walk to the people who work in that center and have even some informal kinds of discussion. Now, if they also have to provide education for the communities, it is easier for them to organize because they live within the communities. They can easily access the communities, provide them with health talks, talks on HIV, talks on diarrhea diseases, talks on safe pregnancies, talks on family planning, those kinds of, they can easily do it with very, very little resources. But if they are not able to do this, either because of funding, because of lack of training, because of lack of capacity, then you have the secondary health facilities inundated with people who come with primary health care problems to secondary healthcare facilities with specialized people who don't have enough resources to take care of them. So you now have a real problem, and that is the kind of challenge we currently are facing.
Okay. All right, Prof. Thanks very much for that. Okay. We have here Dr. Janet Ekpenyong, who is the DG of the Cross River, the Agency for for Primary Health Care. I think my next question will go to you, Dr. Ekpenyong. What I would like to know from you is, if I walked into a primary healthcare facility in a remote area, so let me say maybe one of the PHCs in Akampa, for example, what am I likely to see? What sort of services am I likely to be able to access at that facility? So we're now moving from, I guess, sort of a generic, this is what is supposed to be within a primary health center, to now what actually obtains. If you can paint that picture for us, we'd appreciate it.
Thank you very much for having me here, and very good evening to everyone who's joined. At the primary healthcare level right now, we expect that once a client walks into the health facility, the health worker, of course, will welcome you and give you seats to sit, and of course try to ask questions on why you're here, carrying out a history of what's the problem, why are you in the health facility, and afterwards, the basic vital signs are taken, check for your blood pressure, body temperature, and based on the information they get from you, you're either, and of course, after examination, it could go further to want to carry out the basic tests that we offer in the health facilities. And is, of course, if it's something that it's beyond what they can manage at the facility level, of course, just the basics such as malaria, diarrhea diseases and the rest of it. If it's something that's beyond what they can manage, definitely you have to be referred to the next level of care, which is a secondary facility. But at that level, it's just the basic care. And if it's even a pregnant woman, of course, we expect that they will get them registered for ANC. At least at that level, we ensure that antenatal care services are provided to pregnant women, and of course, get them screened for HIV and every other diseases, malaria and other tests, and of course, give them all the medications they're supposed to be on and all that. But during examination as well, and of course, so that screening, if they think that that's a serious case that needs to be escalated to the secondary level, at that level also, you are moved or you're referred to the secondary level. And the good thing is that though we don't have doctors in all primary healthcare centers, but they have the facilities where we expect that at least a doctor might see you. What we try to do is, at least in each of the LGAs, we're trying to see how we can get at least, even if it's one doctor, where every other day you move from one major PHC, to another to provide these services, consultation to clients that might come into the facility, especially pregnant women during their antenatal care services. When they come in for antenatal care to assess ANC services. Then, of course, we don't have that currently in all the LGAs, but we are hoping that there are some LGAs that we already have doctors. But for other facilities, at least we try to make sure we have midwives in those facilities. So once we think that what you require is beyond the primary health care, then immediately the health worker will, of course, fill a referral form for you, and of course, you'll be sent to the secondary facility for proper care to be initiated. And so that's basically what happens right now at the primary level. We just render basic services. And the way it's structured, most times usually, let's say the highest level of or cadre that we usually have, it's even the midwives. It's now we're beginning to see that we want to ensure that we have doctors actually visiting these primary health services, because from how inception, how it was structured. You only have the junior community health workers, community health officers, you have the community health extension workers who, and of course the midwives manning facilities. But we are going further to make sure that at least we have doctors visiting these facilities. So at least we're able to take care of some cases that might escalate and ensure that our clients do not die, but it's just the basic services that we render currently.
Okay, Dr. Boyan, thanks very much. So maybe what I'd like to understand from you is there must be some benchmark, and I know delivering healthcare at the primary level will be a challenge because of the infrastructure issue that we have in the country and the state. So, we were aware of those things. But is there some sort of benchmark in terms of staffing, in terms of facilities for each of those PHCs? Is there like a minimum standard that one would expect? You mentioned, I think, dispensing drugs, for instance. Now, are the PHCs all across the, all the wards, which, if I'm not mistaken, would be, I think there are 130 something wards in Cross River State?
No, we have more than that. So we have 3 kinds of facilities at the PHC level.
Mm-hmm.
Yeah, so we have what we call the comprehensive health facilities, the PHC, as well as the health post. So it's a health post we expect to see in all communities. Now the PHC, those are like the major facilities that we expect each ward should have, that serves as where others feed into, before the clients are sent to secondary facilities.
Sorry to interrupt you, but I think this is exactly where I wanted to get. So you mentioned the health post. So there's that hierarchy. If you can just start from the lowest level and then just build it all the way up to the secondary, I think that that sort of information would be useful for us.
Okay, so at the health facilities, for instance, at the health post, we expect even a CHU to man a health post, a community extension worker, community health extension worker, yes, because at that level, you're just there to make sure that whoever comes in, whatever basic care you can give, check their blood pressure, check the, random blood sugar, and whatever complaints they have, just provide very the basic services. But if it's something, and besides, structurally, just a very little building with just about two rooms, and sometimes because of limited structures and all that, sometimes if a community might just give us 1 room for us to use. But that's like initiating that first aid care to whoever might need immediate services. And of course, you can now refer them to the nearest, that's a much bigger PHC, where a more, I'll say more comprehensive care could be rendered, like maybe you have to do some laboratory testing, and the rest of it. Of course, at the health post, you don't have that. Now, at the level of the PHC, that's where, of course, we're expecting to see at least 4 junior CHUs. That's the junior community health extension worker. You're also expected to see about 4 CHUs there as well. That's community health extension workers themselves, and of course a CHO, community health officer, as well as a midwife. So we are talking about having about 10 staff in that facility. That's even apart from the ward orderlies, the security men, and the rest of them. But honestly, realistically, that's not the case. So we've also had to, and of course, a lab technician, as well as a pharmacy technician. But because of sometimes lack of manpower, you had to also try to redistribute, and also what we do about like tax shifting, where you have to train people, who probably you just have to train them, on certain things for them to, share tasks here and there. And because you're trying to make sure at least every facility is manned by a health personnel, we don't have that number. However, we're working towards achieving that and ensuring that at least in each of those facilities, we can have up to such numbers in the facility.
Okay. Yeah, Dr. Kwenyong, thank you very much. The other question that I wanted to ask, and I think you're probably the best person to answer that, is, at these health facilities, are there any services that are free to people at the point of delivery? Are there services that are free? Are there services that people have to pay for?
Okay, yes. So currently we have the Basic Healthcare Provision Funds, which is currently a federal government initiative to ensure that those who are vulnerable, and the vulnerable, of course, refer to children under 5, as well as pregnant women, accessing free healthcare services. And we have just started that in Cross River State, and children within the ages of 0 to 5 years access, as far as you're being registered under this scheme, they access free healthcare services, even including pregnant women as well. However, it's not all or every pregnant woman or every child in Cross River State within that age range that is covered, because of the limited funds that are available that can only cover just a few. But however, that has also gone a long way to really help a lot of families, because we really ensure that it's those who really need these services, as well as who do not have people that can actually pay for health services, they're the ones captured and are accessing these services for free. So currently, that's what we have, as well as the health insurance, which we are also we've initiated, where we expect that people should pay just a token. And of course, whenever you need healthcare services, you can walk into the health facility and access health services.
Okay, all right, thanks. So you mentioned that there's provision for, I guess, as part of the state's policy, to provide
children under 5,
children under 5 and pregnant women.
Pregnant women,
I guess due to the limitation in resources, that's not extended to every pregnant woman and every child under 5. So what then is the process for determining who has access to that and who doesn't? And it's the sort of thing that, knowing how political our environment can be, is that something that politicians would, for instance, use to induce people to support them?
Okay, so interestingly, we are very careful in actually selecting the people that benefit from this scheme, and we make sure that these are people that the communities themselves, they know, and they are the ones that recommend them to us. So it's not no politician recommends anyone. We go into the communities, and the good thing is that even the health workers, they are all residents in these communities. They know the people that have been coming to the facilities, those that are really vulnerable. So we ensure to get recommendations from the community members who actually know these people, and of course they know they can't afford such services. So we don't it's nobody else recommends them, or any politician has hands in this. It's totally community based, and they are the ones that actually let us know the people that really need to be captured in this scheme.
Okay, thanks very much. I saw Dr. Iwara. I'm not sure if he's dropped off, but permit me, Dr. Kwenyong, to still, I guess, direct a couple more questions at you. So I'm interested in knowing, I know there was a bill passed, health insurance bill passed in, was it 2016, if I'm not mistaken? And I think that was supposed to introduce the Ayade Care initiative. Can you tell us about that, and what is the impact of that on healthcare delivery in Cross River State?
Okay, thank you very much. We know that in as much as we expect government funding should really help solve most of the problems in the health sector as well as other sector, we know that's not sustainable due to other competing priorities. And that's why in every, globally, health insurance is really recommended, because that's a more sustainable way of financing the health sector. And that's why of course, state government thought it wise to also key into the National Health Insurance Scheme, which was decentralized, and expected that every state should implement such policies, a policy in their various states. And of course, we had commenced the health Ayade Care. Recently, we just started enrolling people, which by next month, we expect.
Hello?
Expected to start assessing care. It's expected that once you enroll, 90 days after enrollment, you can start assessing care. So we have just enrolled people into the scheme, and we hope that by that, when it's complete 90 days, they will start assessing care. And even the formal sector as well has also been brought in, which they're about to commence their enrollment. And this is all geared towards ensuring that we can have enough finances in the health sector to sort out some of these challenges that we are having, be it manpower, be it infrastructure-wise, be it ensuring you have all the commodities and drugs in the facilities. So before they can actually commence assessing those care, we want to ensure that those facilities that are going to be empaneled, that we want to ensure that at least they can be able to have start assessing the healthcare. And I'm glad that a couple of facilities right now, about 58 facilities have been picked to start rendering these services at the primary level. And then of course, automatically the secondary facilities are going to be empaneled to provide these services, as well as the tertiary and a couple of private facilities, because we've also realized that in some communities or in some LGAs, we have private facilities that are even closer to some of the primary healthcare centers that could serve as referral, for clients to be sent there. So these are all things that we're already putting in place. And I must say that in the coming weeks, people are going to be going into health facilities to assess care. And I'm glad that right now we already have like 5 facilities that are already providing the health insurance health services, to people. We're hoping to keep improving and escalate to more facilities. But the General Hospital Calabar, at least they've empaneled some people and they're already assessing health services. We also have people even at the primary healthcare level who have also started assessing healthcare, to the extent that we've even referred to secondary facilities. So that is already in place. And we're hoping as we get more resources pumped into the system, it will really help us sort out all those challenges we're having.
Okay, thanks very much. So it sounds as if, correct me if I'm wrong, but it sounds as if this is still very much at the takeoff stage. Would that be a correct way of describing it?
Just few facilities are providing the services. It's
Okay.
not all the facilities. And that's why I said the ones providing services right now, and even at the primary level, is about 5, but we've actually included about 58, which in the coming weeks, they'll be providing those services. Then at the secondary level, we already have the general hospitals providing the services.
Okay, all right, thanks very much. I don't know if we have Dr. Wara back. I wanted to ask him because, you're a political appointee, I would imagine. He's a permanent secretary. The health insurance scheme is Ayade Care. The next person who comes on board, what's likely to happen with regard to that health insurance scheme? Are we going to start afresh? Is it going to be renamed? Is it going to be retained and expanded? I don't know, maybe you might want to share your thoughts on that, but maybe that would have been a question for the permanent secretary rather than
Okay,
you.
I don't know if I got your question well. Did you say something about maybe outliving this present government or well?
Yes, exactly.
Okay. So the way it is captured in the law, it's not higher daycare, it's Cross River State Health Insurance Scheme. So definitely it would outlive this government. So it's not, it's more like, okay, the Obamacare and all that, but it's not, that's not what's captured in the law. Yeah, it's Cross River State Health Insurance Scheme. Yeah, and of course, we once IAD leaves, any other government that comes in definitely have to just continue. We are just trying to make sure that we lay the foundation, and of course, in the coming years, the health system won't have to rely on government. I mean, you can just run, and just keep going even without relying on government funds.
Okay, thanks very much. I'm going to bring in Dr. Yemisi Femi Pius. She's had extensive experience, dealing with delivering healthcare services at the primary healthcare level. So it will be good, Yemisi, to get your perspective. But I'm going to run a poll. We'll run a poll quickly, and I want to ask. I appreciate that we've got people from all across Nigeria and all across the world here. So I would ask, if you're not based in Cross River State, or you haven't been based in Cross River State, don't respond to this poll, please, so that the data can be meaningful to us. So the question is, when was the last time you visited a primary healthcare facility in Cross River State to access healthcare? So I'm going to launch that. Please ignore it if you don't live in Cross River State, but if you do live in Cross River State, would like you to respond to that. Okay, Dr. Femi Pius, would like to hear your perspective, please.
Okay, good evening, everybody. Thank you very much for invitation to be part of this discussion. Like he has been established, the primary healthcare, it's like the basic, the first level that the clients, come to receive care. And in Cross River State, we have primary healthcare serving, the different wards in the local government. One of the challenges, that we had while I was in Cross River State was that, yes, the services were available, but one thing we need to understand is that also the attitude and the information that is available to the community is also important. Professor Ikwe was talking about the pregnant woman, and we're talking about the 3 delays, in getting to care. We need to recognize that people also need to know how to respond to healthcare situations. Because for a pregnant woman, we have that delay in taking a decision to actually visit the healthcare. So in cases where we have emergencies, where we need people to act on time, that ability to take decision to say, okay, I'm going to the hospital now rather than later is critical. Because there's so much the healthcare provider can do. But if you don't come on time, they can't really help you. So that's the first stage. So people need to be educated. They need to know, okay, if I see this signs, if I observe this, I need to move immediately because delay is dangerous. And a delay of 1 or 2 hours could make the difference between life and death. You understand? So people need to understand that. The second thing is that the second delay we looked at was the delay in, getting to the health facility. It's one thing to recognize that the health facility is there, is accessing the health facility. I'll talk about the road network. Some of those facilities is very difficult to access them. The way the roads are, especially during the rainy season, it's very difficult to access some of those health facilities. And so what we need to do is that we need to look at working with different sectors in improving healthcare. The transport system, we need to look at how do we ensure that people can get to services when they need it, especially emergency services where time is of importance. How do people get there on time? Another thing is to ensure that the facilities are located, in a way where everybody can access it within, for the pregnant woman that requires emergency services, we say within 2 hours. She has to be able to get services, emergency services within 2 hours. So in distributing health facilities, ensuring that facilities are available, we need to ensure equitable spread across the state so that people can access services as soon as they need it. And then, of course, when we get to the health facility, the response of the staff at the facilities, that means they have the skill and the competence to identify that, okay, this woman has this condition and this is how we respond. And so health care workers must be trained. They must be available, one, but they must also be trained, because if they're available and they don't know what to do, that is also a challenge. And of course, when we talk about the workforce, we need to talk about, even in the facilities, we've talked about commodities being available. We need to ensure that commodities are available for them to, attend to the clients. We need to ensure that the infrastructures, supports, is available to support the care that they offer. Now, another thing about healthcare delivery in Cross River State is that our data, we need to ensure that, health information management system is also working, because right now we should be able to speak with data. This is the current antenatal rate of attendance in Cross River State. Yes, I know that we've had NDHS. I think the last one was 2018. But do we have something for Cross River? So at every point in time, we have data to inform, decisions, to inform the next step, to know where we are right now, where are the gaps, and how do we address those gaps? Data is absolutely critical. That data will just, we'll just be guessing, we'll just assume, and that will be very, very, that won't do much. And so the health information management system, we need to work that out. People must be able to document. There has to be a smooth flow of transmitting data right from the primary healthcare level up to the state. So the state on a regular basis can look and say, okay, at this local government, this is the current healthcare indices, real time. We need to get there, maybe in the process of, maybe not necessarily because we don't have computers, but even if it's paper-based, the flow of transmitting that data must be such that the state can access the data and they can use data to make informed decisions, because that is absolutely critical. And of course, we talked about healthcare financing, health insurance. That's also important, because people should be able to have access to care whenever they need it. Funds should not be a barrier to accessing care. And so it's very, I'm delighted to know that the health insurance scheme has kicked off. Yes, it's just starting, but it has started. And that is something, to commend, the government about. At least it has kicked off. And we hope that at least they will spread to more facilities and a lot of people can benefit from the health insurance. And of course, we can't rule out leadership and governance when we talk about healthcare. That's absolutely critical, it's essential. The leadership and the governance, it's important. We must have leadership, we must have governance on how the health care system works in every local government, at every senatorial district, and of course at the state level. So that is also critical. So I think those are my few contributions as regards, healthcare in Cross River, and then some of the areas we need to look into if we want to improve, the situation. Thank you.
Okay, thank you, Dr. Ferry Pius. I think I will throw a question back at Dr. Ekpenyong. So you mentioned the importance of data. Data is absolutely critical. You need data to plan, you need data to appraise, the success of what you're doing. Also, I would imagine that within healthcare delivery, the information records of patients is, very important, and that needs to go. So if you're referring someone, I know Dr. Ekpenyong talked about getting a referral, and I think that's probably paper-based to a hospital. Now, my question is, where does technology come in terms of, capturing data? Or if not technology, how do you capture data that helps you with your planning? And then, is there any centralized information management system where, you visit a health facility, a PHC, your records are there, you're referred to to a secondary health facility, they can see your records there, they can update the records, and those records updated are available to the officials at the primary health facility, so that the history of a patient is there for all health practitioners to see. Dr. Ekpenyong.
Thank you very much. Indeed, issues around data has always been a very huge challenge. And what Dr. Yemisi is saying is that was like what has always been the norm. However, I'm glad to say that we've been able to tackle issues around data generation of all our programs right now. And in as much as maybe at the facility level, most of the data gathering has been paper-based. However, we have times when we make sure that everybody gathers and we try to see how it's captured electronically, and of course further sent to a more central management system all the way to the federal level, because some of these data are demanded to be sent from states all the way to federal. So we ensure that that is done. But in terms of at least having ensuring that clients' information are captured electronically and all that. We have just commenced that to ensure we can have the whole EMR set up in health facilities as part of our ways of ensuring that we activate facilities. We also ensure that laptops and all that are provided in our facilities. And that's what we have started with. And a history of clients that are visiting are being captured in that, in those devices as well. And even at the facility level, and not just facility level, some program officers, we've made sure that even before you're made a program officer of any program, you must have all these devices, either is a laptop or any other device, to make sure that you have all this information captured, because you need to be sending those information sometimes at the daily, depending on the program. For instance, like COVID vaccination that is ongoing. I mean, data is generated daily, from the various communities or facilities or anywhere where vaccination is taking place. And then we get them at the state level and of course, forward them to the federal level. So these are things that we've tried to ensure that we bridge those gaps that have been existing in the past. And we've, at least for programs, we've been able to do that. Now it's at the facility level where information of clients that we've just come in, like I told you, because we've deployed as part of activating facilities for health insurance. We're ensuring that clients are being captured. People are being captured in those, ensure that we can strengthen the entire EMR system, in the state. So yeah, it's been a huge challenge, but I'm glad that at least it's not as it used to be, even when Dr. Yemisi was around. A lot of things have improved since then. So most of those data, we have them handy, and it's been really helping us in making decisions, as well as seeing how we can improve things.
Okay, all right, thanks. I may come back to you with one more question, but I know we've got pharmacist Ezong Sunday on, and of course, you can't talk about healthcare delivery without drugs.
Yeah.
So I would really love to know, I don't know, what his involvement in the delivery of pharmaceutical services is, but, I'd ask you to unmute yourself in a moment and introduce yourself and then, give us your perspectives. But there are a few comments that have been posted while we've been chatting, and I'll just see if I can read out a few. So Elizabeth Edu says, what is the criteria for your selection of children under 5 and the pregnant women? You've probably addressed that already. She says, even at the local government level, this selection in most cases are highly politicized. How do we know that the process of these selections is devoid of favoritism? So I don't know whether she's speaking from experience, whether she's speaking from actual experience, but what she's saying is that it is politicized, despite what you said earlier. I don't know if you want to respond to that briefly.
Is it me?
Yes, if you want to. I mean, you've spoken about
I didn't hear you, please.
Okay, Elizabeth said that she was asking about what the criteria is for selection of the pregnant women and children below 5, because she says, and she seems to be speaking from a place of experience, that it's highly politicized. I know.
No, it's not politicized at all. And like I said, we get the people from the community. They are the ones that will recommend those vulnerable groups, to us, because we don't live there, we don't know them. And the health workers living in that communities too have to confirm that these are people that are actually based in this community. And yes, they maybe due to their constant interaction and engagement with them, they would have seen them in the facilities. And of course, we even know their family members. So those are the things that we ensure to, follow up. The community members themselves must recognize that this person actually deserves to be, captured into the scheme and is actually vulnerable. But children under 5, as far as a child under 5, and based on the number that community is given, then we ensure to capture them. But at least for pregnant women and the aged, we try to make sure that you don't have someone who can actually pay for your health services. But because if you do, then we don't consider you at all. So it's not politicized.
Okay. Someone else is asking how those beneficiaries identify themselves. Is there like cards or something that they show?
Absolutely. So when we bring them in, we register them and cards are given to them. So whenever they want to access care, they just come with their cards. And even when the cards were ready, we made sure we reach out to them. Some of them were taken to their houses. Some were called to come to the facilities.
Okay. All right. Answer says, I had a young lady tell me that.
Them up.
Okay.
We're called to come to the facility, them up. Yes.
Okay. So another comment there from Answer, she says that I had a young lady tell me that her 5-year-old was not immunized and she didn't plan to because hospitals are where people go to die. So how does your agency, we know that there are cultural issues. There are, and some of these are based on perhaps ignorance. Some are based on, just apathy, really. I just feel, what's the point going to my PhD? There's nothing going on there. How does your agency and the Cross River State government overcome this? Do you have any deliberate strategies for overcoming some of these things so that people actually see the benefit of accessing these facilities?
Okay, yeah. So these are some of the challenges we still encounter, where parents, well, for some reason or the other, would just deliberately keep their kids back home and forgetting that you're even risking the lives of other children. And that's why it's because of such cases that we even had to go to the House of Assembly to see how they can come up with that law to insist that even before children are admitted into school, you must show, your card to show that you've been fully vaccinated, fully immunized on all the routine immunization. So for such, we just keep talking and sensitizing and engaging with parents, until we're able to convince them. I'm wondering why she has that impression that health facilities are where people go to die. I mean, over the years, vaccines have always been what has helped us, in eradicating a lot of diseases, as well as, ensuring that we do not record even new vaccine preventable diseases. So it's just probably her cultural beliefs. And yes, we do come and encounter, we usually encounter such people, or maybe her religious beliefs. Not really religious, because it's just whatever beliefs she has. And we always seek to even know who these people are, so that we even send a team or we visit such families, to talk to them and advise them. And eventually we usually get their buy-in, because we're able to allay whatever fears they have. But from the angle of the law, it's the State House of Assembly is working on that, and very soon, children who are in Cross River State, that law will be out hopefully very soon. They must be vaccinated, at least within children who are under 5. Like every child who is resident in Cross River State will have to be vaccinated, because we have to take such drastic measures to ensure we can protect every child in the state. Because if one child comes down with such, you're sure to have over 10 children being infected. So I will even be happy if she can even let us know where this person is, so we can actually go and engage and try to talk to them and convince them and lay whatever fears they have, and ensure that their children are vaccinated and protected against the vaccine preventable diseases.
Okay, Dr. Boyan, thank you. I suspect maybe that comment was expressed in a slightly, well, for want of a better word, exaggerated form.
Absolutely.
But I think, no, but I think there's a very good point there, which is that a lot of people within our society, and we've got to acknowledge that, will first go to their pastors or their prophet, whatever, to access or go down maybe the traditional route. So there is that. And I think it's something that the government, I guess, probably needs a deliberate strategy to overcome, because people may not necessarily say, oh yes, hospitals are where you go to die. But in terms of how they relate to hospitals, it's when they've tried everything else and nothing has worked, then they end up there. So in a way, it's still the same thing. But thanks very much. We have Dr. Iwara back. Welcome, sir. I believe you can unmute yourself. You are the permanent secretary for the Ministry of Health, if I'm not mistaken. I would like you to, I came across a report, during my preparation for this conversation, that said that I think Cross River State had one of the least number of doctors employed within its healthcare service. If I'm not mistaken, I think the number was 33, and it ranked amongst the lowest of the states in Nigeria. Dr. Iwara, maybe you can tell us why that is and what the state government is doing with regard to ensuring that we have the right number of doctors and nurses.
Yes, thank you very much. I'm Dr. Iwara, the Permanent Secretary, Minister of Health.
You're welcome.
Yes. I don't know, am I being heard well?
Yes, you are loud and clear.
Yeah. Yes. Yes, if the number is low, that is great, but I don't know how it relates to other states. Yes, we've had instances in the past where doctors have been employed, and we also still have a standing open, what I would call an open approval for us to employ in the state. We employed a few doctors, but the problem we have had is that oftentimes when the doctors are employed in and there's another employment opportunity in the teaching hospital and other federal parastatals, the doctors tend to leave and migrate to those other places where the pay seems to be better. And it is in that respect that we've been fighting to make sure that we also have our doctors on the same pace and the same pay as other doctors in other establishments, especially even the federal establishments across the country. It is on that note that my commissioner, the past commissioner, Dr. Beth Aidu, before she left, she was able to secure the government's approval for CONMES implementation. And just as I speak to you, last week, I was able to get a mail which she had transmitted to the Auditor General of the state, as well as this Accountant General on that issue. And I want to tell you that we are on our toes, and I've been on my toes also, speaking with the Auditor General. We are expecting that sooner or later, that implementation will be done. And that will give us the impetus now to be able to employ alongside with the already given approval some other doctors. And it is our belief that with this new employment, the doctors won't find it easy again to run away to the federal institutions when the opportunity arises. I want to assure you that there's going to be an end to it. There's a light at the end of the tunnel. Having now gotten the approval of His Excellency Professor Ben Ayade to implement the CONMES in Cross River State. This has been our headache, and we have come to surmount it. We believe that we are sure to be able to end this in Cross River State, and therefore increase our numbers as the need arises.
Okay, Doc, thank you very much. It sounds as if things are happening, but both,
yes, indeed.
If I take the feedback of yourself and Dr. Peyon, it sounds like things are happening, but they are happening at the tail end of this administration, which is quite a concern. I guess the administration's priority had been on industrialization. It does sound to me that the provision of healthcare hasn't really been on the front burner for this administration. Would you want to lend your view on that? I know civil servants are neutral or supposed to be.
Yes, it's not so. It's not completely so. If you agree with me, you'll agree with me that the governor of the state has been one of those who have been very, very proactive in terms of improvement of the healthcare status of the cross rivers as a whole. This issue of unemployment of doctors or low employment of doctors or low engagement of doctors has been the burning issue, not only of this administration, but of the very past administrations. We've had the means of trying to see how we can retain doctors that have been engaged in employment. You will remember some time ago, we talked about how we can improve the system. My friend is here, Prof. Ederick is here when he was commissioner. He made an effort even to ensure that we got doctors in the engagement who are engaged in the state to even take up a kind of residency program, which of course at the end of the day didn't see the light of the day because of the teaching problems that were not addressed at that time. Beyond that point, in this present administration, I am telling you that yes, the government has identified the loopholes, and one of the key issues has been the parity in the pay between the state government and the federal institutions in the state, particularly the UCTH Calabar. And so there's been a lot of migration of staff from the ministry to that area. And for us now, we have seen that we've been able to achieve that by also getting an approval of the governor and then for governments. And it is this that is now going to be the yardstick for us to engage more doctors who, of course, we are sure will be able to be retained in the system. So we hope to have a paradigm shift this time around and things will come. The fact that it's coming towards the end of this present administration is not, of course, to say that it's not going to be implemented. The major issue is, have you gotten the approval and are we going to implement it? And is it going to give us positive results? Yes, we expect to have that.
Okay, all right, thanks very much. I see Dr. Ekpe's hand is up, but sorry, Prof, please just hold on. Let me bring in the pharmacist, Ezong Sunday. So if you want to unmute yourself, introduce yourself, and we know that drugs are important for healthcare delivery. Challenges with transferring drugs to primary healthcare centers.
Good evening, all.
Good evening.
Okay, my name is Pharmacist Ezong Sunday, and the PM, the program manager of Cross River State Essential Drug Program, and the also for LMCU coordinator of the state. Yeah, welcome.
Okay, so tell us. So, am I correct in saying that your agency is responsible for the transfer of drugs to the primary health care facilities in the state? If that is the thing, how do you do? How effective are you in doing that?
Yes, that is correct. I'm glad to announce that for now, since 2014, the Cross River Essential Drug Program, abbreviated as EDP, has been in Moribond, and the activity has not been there. It was mandate for to procure medical commodity, especially which drug is one, and then distribute to the last mile, and where it cannot get to the facilities level across the state. That is the mandate. But because the program has not been active for now, we are not taking that responsibility. But be as it may, at the LMC level, we try to drive the supply chain across the states, because the LMCU is a logistic management coordinating unit that drives the supply chain, medical commodity supply chain for the states. At the level, there are program drugs, commodities, for malaria and HIV, and even family planning, that even nutrition that we procure, that are sent or procure from the program implementing partners. These commodities are sent to the state either bi-monthly or quarterly. These are sent to the facilities. We monitor their consumption data, and then also report SIM to through the innovation platform that is accessible to the NPSMP, that is National Product Supply Chain Management Unit at Abuja, and then it is used to resupply to the state either bi-monthly or more quarterly. That is what we are doing for now. But as a state, which we are supposed to have commodities at the central medical store where they can procure and store and then distribute to the state, it has not been done. What is where we are today, that the facility are doing what we call private DRL, not revolving fund, which pending when government will now come up. But that does not mean that government is not doing anything for now. Government has taken a step further by trying to align with the federal ministry policy of introducing MDA, which is a medical commodity agency that is saddled with the responsibility of procuring, having a pool of drugs, centralized pool of drugs, the government and access that will help the facility. That will help the state facilities, including both private and public, to have access to the facility and stock of commodities which are being released in hospitals and other primary health care will be a thing of the past. And that is where we are. The law of that establishing that agency has been sent to the National Assembly, and we are waiting approval so that we can commence the activity. Thank you.
Okay, thanks very much. Thanks very much, pharmacist. So I'm conscious of time, and I want to now sort of have us paint the picture. Where do we want to be? What is the ideal scenario? And we've got some medical professionals on this conversation who are in different parts of the world. So it will be good to hear their perspectives. And at this point, I think I will bring in Dr. Harrison Ofiong. If you can just, I know you probably, your time with us is brief, but if you can just use maybe the next 2 to 3 minutes to just give us an experience that perhaps may benefit Cross River State and where you currently practice medicine.
Okay, thank you very much to the Cross River Movement for inviting me to speak in this gathering. I'm amongst distinguished panelists, especially one of my lecturers, Professor Ikpi, who taught me when I was in medical school. I mean, I'm a Calabar boy, so to speak. I finished medical school from the University of Calabar in 2006, and I left to come and study a master's in public health in the University of Birmingham in 2010. And since then, I've been working in the UK and studying I've been studying and working in the UK. I'm currently a general practitioner, and I think for everyone in the world, the NHS, which is the service that I work in, would be like a model of what a healthcare system should be, because technically, compared with my experience of working back in Nigeria, it's a healthcare system that actually functions effectively, works quite well. And it does have a very similar structure to what we have been discussing so far, where you have the primary care facility, and that is like the gateway to the healthcare system, where you have a general practitioner manning the primary healthcare facility, and what they do is they see everybody. They are the first port of call. Any healthcare problem you have, usually the GP would be the first person you speak to. And what the GP would do would be to take the history, assess, triage, and treat. And if necessary, they can then refer to secondary healthcare facilities. The other aspect of the healthcare system where you can access care is the emergency services, the accident and emergency services. So if you have an acute problem that needs immediate assessment, you can just go directly to A&E, or you can speak to your GP, who after their assessment they would say, you know what, you need to go straight to A&E. So I mean, in a nutshell, that is what the healthcare system is like, and like I said, it works quite well. But I mean, listening to what everyone has said, I think one key aspect of how you can improve the healthcare system is you can have all the facilities, but if people don't have the education and awareness of how to access those facilities, they don't know where to go, how to go, what kind of symptoms they have, then you would have them accessing the facilities in an upside down way, where someone with a simple problem like malaria would turn up in a secondary or tertiary healthcare facility, and someone with an acute problem like a pneumonia or a myocardial infection would turn up in a primary healthcare facility. So I think the most important thing is patient education, letting them know what the problem is. We talked about, I think there was a comment about from someone that they said people just go to the hospitals to die. I don't think it's just a simple comment. I think it pinpoints where the problem is, because if you look at, I mean, I've mentioned accessing healthcare facilities through the emergency system. Over here, if you have an acute medical problem, you call 999, and when you call 999, they send out an ambulance to you, and that ambulance takes you to the hospital. But back home in Nigeria, or in Calabar, when I was there, people associate the ambulance as that's what they use to carry dead bodies. And I had a personal experience myself where my dad had um my dad has passed now, but in 2019 he had a subacute hemorrhage, you know and even though he was confused, he refused to get into an ambulance to go to the hospital, because he had that notion that the ambulance is what you use to carry dead bodies, and if you're getting into an ambulance, that means you're either dead or you're dying. And this is my dad, who was educated to the tertiary level, and he raised me up and brought me to where I am, and I couldn't fathom why he was still having that notion. So I think the problem is quite deep seated. It's not just an issue of employing doctors or retaining doctors. We need to do basic primary healthcare education, to change the attitudes, to change the perceptions, to change the notions of the people. Primary care facilities like vaccination and other things like that, you get that barrier, because people, you can do all you want, pour as much money in as you want, but if the people don't accept it, then you would go nowhere. Sorry, I know I'm a bit short of time, and there's so much to talk about. There's so much issues to discuss and expatiate on, and like I said, I'm really grateful that I was invited to speak. I have quite a lot of experience, and I'm willing to work with. I'm from Cross River. I really love to work with the government, or however, or just give back in any way that I can. So thanks for the opportunity, and thanks for letting me speak. I hope what I've said has been useful. Thank you very much.
Yeah, Dr. Fion, thank you very much for joining. We really appreciate it, especially at short notice. And thanks also for making yourself available to, contribute towards the development of your state. Very commendable. And that's one of the things that we seek to do under the Cross River Movement, is to get people, to provide a platform really where people can come in and engage all towards the development of our state. So thank you, commendable. All right, I'm conscious
Thank you.
We're wrapping down, but now we want to look at, and you've shared with us your experience out in the UK. Professor Edet Ikpe, you're in Saudi Arabia. Do you want to share with us, because you've had the benefit of practicing your profession, not just in Cross River State, but different parts of the world. So it will be very interesting to hear your thoughts around sort of where we ideally should aspire to be, and maybe also how you think we can get from where we are to where we want to be.
Okay, thank you very much. I'll try to be as brief as I can, and I really have to commend other people who have spoken to the subject. But to be honest with you, the Cross River State movement is trying to, is taking on too much. This discussion is so diverse that you can't exhaust it meaningfully in a particular sitting. So if it's going to really make the impact it's supposed to make, I think we need to segregate. So look at funding structures for primary health centers. Look at staffing issues for primary health centers. Look at access to care for primary health. Look at medical recording systems and their use for, so you can have discussions on these particular themes at different levels. And the key operators within the State Ministry of Health and perhaps the primary healthcare system need to be part of that discussion so that they can see how new ways can be brought to the management of primary healthcare centers to ensure that they succeed. All that we have discussed so far is centered on government. It cannot work. It cannot work. It cannot work. For the simple reason that healthcare does not carry enough political goodwill, or it doesn't have a lot of political, there's a term for it. It's not politically rewarding for a politician to engage in healthcare. So the governor fixes all the secondary health facilities. He's not going to be applauded for that, because the patient who walks into that health facility and cannot get Panadol simply thinks he hasn't done anything. But if the governor fixes a road, oh yes, he's applauded. If the governor provides water, oh yes, he's applauded. So healthcare really is not a very good political investment, does not earn the government political capital. So healthcare practitioners and administrators who are interested in healthcare need to have a meeting point where they can discuss outside the box solutions for actualizing healthcare administration. What do I mean by this? There are simple things government can do, okay? Staffing issues. The permanent secretary talked about doctors for primary health centers. You can't get enough. You can never get enough, because the disparity between the state and the tertiary system would always be there. So one of the things which I suggested when I was commissioner, aside from starting a cross-river state residency training program, was to encourage the state government to give scholarships to medical students of cross-river state origin. So cross-river state medical students who are in secondary in university should have the opportunity to sign up for scholarship so that they can go to school, they can have their fees paid, they can have good accommodation without stress. And because they have access to this scholarship, they sign a bond to work for the state government for 3 years to 4 years, depending on how long their scholarship spans. Okay, so if they sign that bond, then you have, for instance, 100 people who are under the state government scholarship as medical students. That means once those 100 people qualify, you have 100 people available to deploy to cross-river state health centers who will work with the cross-river state government for the next 3 years on a salary that will be agreed by the state government. And once they finish, they can now go for their residency training program, whatever they want. And as they are moving from the system, another set is replacing them. So at any point in time, you have about 100 people who are available to work. We must think outside the box. Now, funding for healthcare, it can never work because the money is never, ever enough. The local governments don't even have access to their funds. They don't even have access to their own funds. So where's the money going to come from to fund it? How can we sensitize communities to the extent that they become owners of the primary health center? How can the chief of that community create a fund that is available to that health center for them to buy drugs, for them to buy, so that they can hold the people who work in those health centers accountable for the funds that they have received from the community? As opposed to receiving funds from the government.
Sorry to interrupt you, but what you're saying sounds more like people having to make adjustment for the failure of government. Is that what you're saying? Don't you think that?
No. I don't think it's a failure of government. It's being realistic.
But
it happens everywhere.
You have to know, but why it is failure in the sense that you've got these maybe like health. I can't remember what the fund is, but you have a fund that maybe says a certain percentage of GDP or whatever it is goes into healthcare. So and those things are statutory. So if the government is not spending,
when I was commissioner, they passed the primary healthcare bill, primary healthcare law. Okay, when I was commissioner, and it was first state, the only state in the country that had passed that law. That law required that the state government would provide 1% of its monthly allocation to primary healthcare service. And the local governments will also provide 1% collectively. That would have funded primary healthcare. But once the money was calculated, people were now like, oh, there's going to be too much money in health. It never came. You see, I think this is the point. The point is that we are missing the essence for the primary healthcare. We are missing the essence. The essence is for it to save lives. How we save the lives is a secondary matter. Now, we have a system that is not functioning. The government is supposed to take responsibility. They are failing to do so. Who are the people who are dying? It is my sister, your brother, your uncle, your wife that is dying. So unless you are ready to go and storm the place and drive the people out, we need to think outside the box to fix it. Because currently, people are dying. And that assertion that, well, it's misplaced, those places are actually death traps. You go there, people die, which is why people don't go there. So if the community takes ownership and we create, instead of, that would be my advice. Instead of saying, look, you're going to do a health insurance program, which once Ayade leaves office, Ayade K is dead. Ayade K is dead the day he leaves office. Let's not, I've been in that system, so I understand it. Because the next government is going to start maybe, I don't know who the players, maybe something care. And they're going to jettison this one. So we need to create something that is owned by the community, that is not responsive to whoever is governor, that works for our people.
Okay, all right, Prof.
That's what I think.
Okay, Prof. Thanks very much. Let me go to the DG of the healthcare agency, Dr. Fenyong. If you would like to widen down, so if you'd like to share closing remarks and what you think we need to do to get from where we are to where we want to be. If you can do that in 2 minutes, I really appreciate it.
Thank you very much. I want to say that this has really been very interactive, and I hope we get to do this more often. Maybe this will afford us opportunity to really showcase what Cross River State government is really doing as it concerns health. Let me state here, I'm glad that Dr. Iwara talked about some of the measures we are putting in place to bridge challenges around human resource. And I really want to reiterate that, yes, His Excellency has signed into that. Doctors are going to be paid the same amount, federal doctors who work with federal health institutions to be paid in Cross River State. And this is because His Excellency wants to make sure that they don't have to run to, those institutions or even leave the country because of issues around payment. And very soon that will be taken care of. And let me also talk about the issues of Ayade care. I had mentioned here earlier that the law forming the health insurance scheme, the name of the scheme is Cross River State Health Insurance Scheme, not Ayade care. It will outlive Ayade. So what he's doing now, laying that foundation such that any government that comes in will continue from there. And I've said it here that is the most sustainable way of financing the health sector. You can't rely on government to do that. And we are really working towards ensuring that is implemented. And of course, we're also looking beyond. We are making sure that it works perfectly well before we even leave office. And it might interest you to know that, yes, health has really always been His Excellency's priority sector. It was while in his regime that we were able to ensure that our colleges of nursing colleges, school of nursing was even upgraded. And of course, all the licenses that we required, we got them, and they're all functioning. We don't have any challenges in that regard right now. Even private sector involvement, and it might also interest you that we are trying to strengthen our logistics and ensuring that drugs and other commodities can get to facilities. Right now, we have the zip line. I know maybe you may have seen that. They have it in Rwanda, we have it in Ghana, and several other countries. Zip line is in Cross River State. The structures are already being built where we'll be deploying drugs and vaccines all the way to facilities, especially hard to reach facilities, just to ensure that we can take those services closer to the people and we don't run out of drugs and vaccines in those places. Also, I'm also glad to inform you that we are also thinking outside the box, not necessarily waiting until government employs doctors. We're leveraging on NYSC doctors or health personnel. We are also leveraging, right now we're in talks with UCTH to see how doctors from there can be deployed to states government-owned facilities, and of course for continue with their trainings there, as well as provide other services. So these are all things that we're doing to ensure that we can bridge such gaps, and we'll continue to do more. So I'm hoping that we'll have the opportunity to discuss extensively on some of the things His Excellency is doing in the States. Thank you very much.
Okay, Dr. Kwenyon, thank you very much. Okay, so I think I would ask Dr. Iwara to come in, and if you can, sir, in 1 minute, just give us your closing remarks. Tell us what you think we need to do to get from where we are to where we should be. Dr. Iwara, if you're speaking, you need to unmute yourself.
Yes, thank you very much for giving me this opportunity. Honestly, I want to say that I am happy to be here and also to exchange ideas with all of you, but those of us who are very old there, and then those who are also bringing innovations from the very wide world. I want to thank Professor Ikpi, who has been here, who has shared ideas about what he thinks can make things work. He's been a commissioner before. He has a wide range of experience. I want to thank our friends who are out there in far away, who are also sharing experiences. But I want to say, Cross River State particularly, we have a challenge. And that is because we have learned and seen what has been our problems in the past. Currently, we are in to make sure that we change the paradigm so that we can be able to achieve what is expected of us, also to be in line with the current best practices across the world. Like I have said before, the governor has granted us the government's approval. Once that is in place, we hope to have more doctors into the system. Dr. Janet Penyon, the DG, has also said it very clearly that the Ayade Care, or what we call the Cross River State Health Insurance Agency, is there to change also as a game changer. All over the world, you know that insurance is the key to health financing. Wherever we have practiced it, it is the key to health insurance. The federal government has tried it, and we are also here to make sure that we will mainstream health insurance to make sure that everybody gets into it. It is compulsory for everyone. It is our belief that when we get when everybody is involved in health insurance, we will be able to, finance healthcare to the core as we are expecting it to be. We are committed to it. Everybody is committed to it. It's not been like this in the past, but it's a game changer, like I have said, for all of us in the health system now, to begin to believe that we bring our experiences to bear on what we believe will bring Cross River State to the limelight and also to achieve the success we desire in order to be at the top of healthcare in Nigeria and, of course, of the world. Thank you very much.
All right, thanks very much. Dr. Yemisi Femi Pius, do you want to give closing remarks and tell us where you think that we could bring improvements to the system?
Yeah, very much once again to all the panelists, everybody that has presented. I think that these discussions are important because they start to generate and stimulate ways in which we can move forward and we can implement changes and move the healthcare forward. I particularly appreciate Professor Ikpi's thinking outside the box, because the government can't do everything. That is the reality, and we need to face the reality. We need to start thinking outside the box. Patient education, like Dr. Harrison said, is critical. People must know what to do at every point in time so that they can use rational use of services, because overloading the secondary facility and neglecting the primary health care is not going to get us anywhere, even if the facilities are available. And so I just want to say thank you once again for this opportunity to be part of this discussion. And it's a great thing that the Cross Rivers movement is doing. Thank you.
Thank you very much. I will ask David Etim to unmute and make a brief comment. But before that, I wonder whether the DG, the Permanent Secretary, and other government stakeholders are aware of the growth and development strategy of Cross River State, and if they have at all been guided, if the policies of government have been guided at all by that strategy as it pertains to healthcare delivery. Maybe Dr. Ikpenyong, you might want to just in a few words just respond to that. The growth and development strategy for Cross River State. Nope. Okay. David Etim, please, if you can make your remarks in 1 minute.
1 minute. 1 minute. 1 minute. I just want to align myself quickly with what Professor Ikpi, I think it is, Edet Ikpi.
Yeah.
Yes. The truth of the matter is that in Nigeria today, regardless of what we all want to wish, the country is insolvent. So expecting government at this time to be able to aggregate the funding that healthcare will require to move us forward, I think is wishful thinking. I totally agree with Professor Ikpi that we need to think out of the box. We need to look at other ways and means of funding healthcare. So I'm not a medical practitioner in any way. I'm a businessman. So I can't go into the detailed workings of that, but the broad issue is insolvency. Government is broke. And so expecting government to find money, in fact, paying salaries going forwards may become a huge challenge, even for those that we have now recruited. So I see a situation whereby, you know, insolvency is smack in our faces, and we need to think out of the box. Thank you very much. And thank you to Cross River Movement for a great job. Great job. Thank you.
Thank you, David. Thank you very much. Okay, Edith Young, if you can quickly take us through a couple of announcements, and then we'll bring the conversation to a close.
Okay, thank you very much, sir. Okay, good evening, everybody. Thank you so much for staying tuned with us from the beginning of this conversation through to the end. And thank you to our amazing panelists for all of the insights they have shared. Moving forward, other than the Cross River, other than TCRM Conversations with Issa Obasi, we have another initiative which is called TCRM Talks. And TCRM Talks is an initiative that we have created to bring in people from diverse experiences and backgrounds to engage and educate the public on ideas that can contribute to the development of Cross River State. And TCM Talks works in such a way that, I mean, unlike TCM Conversations, where we have a group of panel discuss on topical issues, for TCM Talks, we have just an individual who comes on board, shares his or her ideas, and then we have the participants engage on that topic. So TCM Talks holds once every month, specifically the first Sunday of every month, which is about the same time, 4 p.m. here on Zoom, and we stream on Facebook and YouTube as well. Our next TCM Talks comes up on the 7th of August. That should be about a week and some days from today. And we will be commemorating the International Youth Day 2022, looking at the topic, Bridging Generational Gap to Foster Development in Cross River State. And I know that we have a lot of elderly people here with experiences, so we're bringing a younger person to shed light on that topic and see how we can work with the older generation to bring development to Cross River State. Okay, having said that, I'd like to take on other announcements. We're welcoming all of our new members, and we would then implore you to visit our website, which is in the chat room, www.crossrivermove.com. There you can sign up and get more information about what we do and how you can be a part of what we are doing. Kindly follow us on Facebook and on YouTube at Cross River Move. And our next TCM conversation with Issa Obasi would come up on 14th of August 2022. And we're also going to discuss a topical issue that throws more light on the International Youth Day celebration theme, which is bridging generational gap to foster the SDGs. Okay, have a great week ahead. That's about all for now. Please remember to subscribe to our YouTube channel. The replay of these conversations and talks are always on YouTube and Facebook. So we'd like you to subscribe so that you can have access to information as early as they come. Thank you very much, sir. Have a great day, everybody.
Thank you very much, Edidion, and thank you to panel for making out time from your busy schedules. Really appreciate you, and to every guest who's turned up on this conversation and for the comments that you've made, the contributions. Thank you very much, and have a wonderful rest of the weekend, and God bless you. Bye-bye.